多謝你啊，多謝大家同陳醫生俾個機會我哋上嚟同你分享啊。咁一陣嗰位 guest speaker Dr. Irene Lau 其實係我自己兩個小朋友嘅 dentist 嚟嘅。咁嗰陣時我女箍牙，咁我都好多問題想問，即係關於啲牙夠唔夠位啊，個 jaw 嗰度點樣咁啊 Dr. Irene 俾咗好多 insight 我，變咗我都即係覺得呢樣嘢係好值得大家都要知道嘅。咁成日都會有人問我啊，咁點樣先令到個樣最靚啊？究竟棚牙如何啊？塊面點打針啊？或者黑眼圈去點樣去改善啊？不過原來係從小都可以去改善呢啲問題喎。咁所以我就將呢個時間直接交俾Dr. Lau Irene 啦。
Hello， 大家好，多謝Professor Chan 同埋 Timothy 今日請我上嚟分享。所以 my topic today is ABCs of sleep disorder breathing in children, a dental perspective. And me myself, I'm a pediatric dentist. And let me introduce myself a little bit. I graduated from New York University in 2003. And then I went on to do a general practice residency at New York Hospital Queens, which was a Trauma One center. Then I was trained at Mount Sinai in pediatric dentistry. And that was the first 10 years of my career. The second 10 years of my career, I moved back to Hong Kong. And I currently practice in 2 private practices, and I also have an NGO called Hello Smile Hong Kong, which serves underprivileged children in Hong Kong. And I want to point out as well the title of this talk, ABCs of Sleep Disorder Breathing. A lovely colleague of mine had coined that title because ABC also stands for airway, breathing, and circulation, and which perfectly describes our talk today. Now, I'd like to start with a case. This actually happened in my clinic with one of my colleagues. And this 3-year-old female patient presented to the clinic for dental treatment under MAC sedation. And the dental history, we found multiple carious teeth, and the child was not cooperative for dental treatment. So we decided that she needed sedation for the dental treatment. And her behavior was, she's anxious, unfocused, has tantrums, irritability. And mom reported of progressively worsening of her behavior in general. And the pre-op assessment, she was only at 13 kilograms, which is only 50 percentile weight. And she has eczema, we can see in the photo on the corner of her mouth. Allergic rhinitis, a receding chin. She's prone to sleeping on one side, has restless sleep, and she was actually seen by an ENT at 2 years old. And they have found enlarged tonsils and was only recommended for observation and was told that she would grow out of it, and no ENT follow-up afterwards. So what happened during our MAC sedation? Normally we start with a gas induction with sevoflurane and oxygen, and the anesthetist would put in an IV cannula. At this point, there was no drugs put in the IV yet. Unfortunately, there was an oxygen desaturation to about 40 to 50% with insucking of her chest during inspiration. And luckily, the saturation was improved with the use of oropharyngeal airway and assisted ventilation. And it was found that she has a grade 4 tonsils, large tongue with a tongue tie, red swollen turbinates on both sides. And because of the severe upper airway obstruction, we had to postpone the dental treatment. And she was referred to an ENT with experience with pediatric sleep disorder breathing. And with the ENT, what the ENT found was she's snoring during sleep with witness apnea, nasal obstruction, mouth breathing. She grinds her teeth at night. Enlarged inferior turbinates, 100% adenoids. Grade 4 tonsils, she has a tongue tie, Coriolis 2 tongue tie. Elongated uvula, platythorax, and Harrison sulcus. She was diagnosed with severe obstructive sleep disorder breathing. She then went on to get surgical treatment. She got a turbinate reduction, adenoidectomy, tonsillotomy, and linguophorectomy. And 3 weeks later, her teeth started hurting again, so she came back to the clinic for dental treatment. And mom reported that her mood and behavior at home and in school have dramatically improved. Even the teacher have complimented on her behavioral changes. And she's sleeping well, and there's less eye shiners. Complexion has improved significantly. We can see the before and after photo This is before, after. We see her face is much brighter afterwards. We see the dark circles is less, and even her eczema is gone. We can see even her hair is less messy in 3 weeks later. So we were able to complete the dental treatment without sedation. She was able to cooperate in the dental chair. So what almost became a severe adverse event under sedation fortunately had a positive outcome for this child. But how can we have served her better if we were able to recognize her signs and symptoms much earlier than before we proceeded with the sedation case? Could we have prevented this? So what is sleep disorder breathing? It's a spectrum of conditions caused by repeated upper airway collapse. A narrow airway with reduced neuromuscular tone, increased collapsibility, and it's associated with abnormal gas exchange, intermittent oxygen deprivation, fragmented sleep, and restorative sleep. So if undiagnosed, it leads to symptoms that are often overlooked, like restless sleep, frequent awakenings, enuresis, lack of focus, disinterest in eating, gastric reflux, ADHD symptoms, anger, poor school performance. And this is the spectrum. So normally we see children that starts off with mouth breathing or noisy breathing, occasionally snoring. And a lot of times the parents would complain that their kid is always drooling because when they're sleeping, the mouth is open. Or during the day, the mouth is open. And we may start noticing a little bit more of behavioral issues, and they will start snoring more regularly. And then as we progress, we get to upper airway resistance syndrome, where there is more arousals during sleep, and they're not able to focus in school more. They may be diagnosed with ADHD at this point. And if the child is not treated at this point, they may progress to sleep apnea. And we can notice that with sleep apnea, we see the jaw deformity. And we know that as this progresses to an adult OSA, it's very difficult to treat. So if we're diagnosing OSA, we're already too late. We should be looking at them a lot earlier. Maybe a 1-year-old that are mouth breathing and look for underlying issues. Why are they mouth breathing? Or a 4-year-old with, maybe some ADHD symptoms, deep bite, we could see the eye shiners under the eye, and start looking from there instead and reverse their symptoms for them. So this child is actually my patient. I met him when he was 9 years old, and he was already diagnosed with obstructive sleep apnea. We could see the forward head posture because of his mouth breathing. So his head is forward with the spine curving forward. And intraorally, we could see the palate is very narrow. He has a huge overbite, a deep bite, small chin. So in Chinese, we call this 哨牙. And 下巴 is very 好短. And the picture on the right is him when he was 4 years old. And I asked mom to send me a photo of him when he was 4 years old. So like I said, we could already see all these signs and symptoms when he was 4. So if we had caught him earlier, he wouldn't progress to OSA. Dr. Christian Guilleminault was the first to report on condition of sleep apnea in children in 1976. In his study, 8 children were diagnosed with sleep apnea syndrome, similar to adults, and the children displayed symptoms like abnormal daytime behavior, decrease in school performance, enuresis with loud snoring interrupted by pauses during sleep. And some of the risk factors for child OSA, I won't read the entire list, but I like to point out the complications of childhood sleep apnea, especially neurological and behavioral issues. ADHD, parasomnia, sleepwalking, nightmares, aggression, and nocturnal enuresis. These symptoms are oftentimes overlooked. And what's the prevalence of obstructive sleep apnea? This paper reviewed 30 studies, and there's a high degree of heterogeneity in methods and definitions used for OSA. But it shows that before 2014, there's 3 to 9% prevalence, but studies between 2016 to 2023, there's a 12 to 20% prevalence. So the prevalence of OSA has been increasing. And there's no full agreement on the classification of OSA severity in children. Many studies uses the AHI to categorize OSA. Mild OSA is AHI 1 to 4.9, moderate is 5 to 9.9, severe AHI is over 10. But there are other objective findings, such as presence and length of oxygen desaturation, degree of hypoventilation, sleep fragmentation, and decreased total sleep time. And it is also very important to note the severity of the PSG finding does not always correlate with the degree of morbidity. So treatment decisions should be taken into account the child's symptoms and relevant comorbidities in addition to the PSG findings. Now, besides the PSG, another way to evaluate the upper airway is the drug-induced sedation endoscopy, DISE. And this is usually done under sedation with medications such as midazolam, fentanyl, and propofol. And we can evaluate the site of obstruction, whether it's at the velum, oropharynx, tongue base, or epiglottis. And at the retrolingual level, the degree of hypertrophy of lingual tonsils and features of the reflux laryngitis commonly associated with OSA should also be noted. Now, this is a video of nasal endoscopy. This is from Dr. Su. I'm not sure. Probably under 6. Yeah. Yeah, so with the endoscopy, we can see clearly where the obstructions are. Yep. Okay, that's it. So, now what is optimal breathing? It is quiet breathing, exclusive nasal breathing, lips closed, tongue is suctioned naturally to the palate. And we can actually all try this now. Place your tongue on top of the mouth on the palate, and breathe through your nose. And and now put your tongue on the bottom of your mouth, and then now breathe through your nose. Now, do you notice it's more difficult when your tongue is down? So naturally, our tongue is actually, its natural state is on the palate when we're resting and we're not talking. So this way the tongue doesn't block up the airway, we can breathe properly. Now, why is nasal breathing important? It enhances oxygen absorption by our lungs via nitric oxide production from the sinuses. It allows proper craniofacial development, TMJ function, and head posture, and can influence growth and development. It's associated with teeth grinding and TMJ dysfunction. And intermittent mouth breathing results in sleep disorder breathing. Now, if nasal breathing is not optimal, we find these symptoms of signs and symptoms of sleep disorder breathing. This is my intake form at my clinic, and this is from courtesy of Dr. Audrey Yoon. We see all the symptoms listed there: teeth grinding, mouth breathing, tongue tie, bedwetting, allergies, asthma, crooked teeth, restless sleep, nightmares, many different symptoms. But I like to focus on ADHD. So this was a study by COHK in 2010 on the prevalence and risk factors of habitual snoring in children 5 to 14 years old. And they have found that habitual snoring is associated with sleep disorder breathing and adverse neurobehavioral outcomes. And it's associated with poor temper, hyperactivity, unfocus, and poor school performance. This is another study on children between 9 to 10 years old, obstructive sleep disorder breathing and behavioral problems associated with brain structure alterations. And we found that children with OSA with behavioral issues have smaller volumes of multiple frontal lobe regions. And what is our frontal lobe for? It regulates attention, memory, problem solving, behavioral inhibition, language, apprehension, emotional control. And the strongest association is the frequency of snoring. And if left untreated, these OSA cases, they will have neuropsychological or executive dysfunction in developing children. Now, this is actually my study on sleep disorder breathing in Hong Kong children, which examine pediatric SDB and behavioral symptoms pre and post ENT surgery and maxillary expansion. So this study was actually inspired by my mentor, Dr. Stanley Liu. He's a world-renowned sleep surgeon in the US, and I presented this data in the World Sleep Congress in Rio in 2013. So what we did was we took 105 children between the age of 6 to 14 years old with SDB symptoms. And we used the Conners ASQ questionnaire to assess their behavior pre and post treatment with a score of equal over 15. The patient would need further assessment for ADHD. And we found that an astounding 83% were reported with behavioral issues. And the majority of these patients have allergic rhinitis. And 35 out of the 105 with significant SDB indices were willing to go through a sleep study, and 33 underwent surgery, upper airway surgery, and 18 out of the 33 had expansion of the maxilla. So what we found with our results was there's a significant decrease in the Conners ASQ score pre and post surgery. And the Conners ASQ scoring was a parameter showing improvement of behavior after upper airway surgery and maxillary expansion. And there are a lot of other studies out there that shows the same thing. So do our children have ADHD, or do they have ADHD symptoms as a result of poor breathing and sleeping? Now let's understand the airway a little bit. This is just a very simple illustration of the possible sites of obstruction. We can have enlarged turbinates in the nose, adenoids, tonsils behind the throat, and we could also have the back of the tongue blocking the airway. And for me as a pediatric dentist, this is my focus, the craniofacial development and the tongue function, which can cause SDB issues. Now, a child with a SDB and is mouth breathing, what happens to the face? This is a primate study on oral development. So they had used silicone plugs in the nostril of baby monkeys, and they have developed a narrow maxilla, high arch palate, elongated and downward rotation of the mandible, which means a long face, malocclusion, malposition of the mandible. And when we remove these plugs, the lip and tongue return to normal. Dental malocclusion was retained though. And this was a study from the UK on 12,000 children. And they have found that sleep disordered breathing without apnea or any oxygen saturation is more common than OSA. So habitual mouth breathing was at 25%. So there needs to be an early and continued screening in early childhood. This was from a study with Dr. Guimino. It was a diagram showing mouth breathing. It's a vicious cycle. So what happens during mouth breathing? We get local inflammation, tonsil enlargement, worsening of poor nasal breathing with increased upper airway resistance, systemic inflammation, postural maladaptation, abnormal orofacial development, and then this continues in a cycle. So a profile of a chronic mouth breather, we see the small chin, flat nose, forward head posture, and it could also cause vertical maxillary excess, which means a gummy smile. So nasal breathing promotes improved development of the maxilla. And with mouth breathing, open mouth posture, we have a open bite, long face, vertical growth. And it is very important to note that craniofacial development reaches up to 80% by age 6. So we shall be looking at our children much younger. So Michael Phelps, we all know him as the Olympic swimmer. But he has a long face and a narrow palate. So C.V. Tomes coined the term adenoid face associated with chronic nasal airway obstruction mouth breathing. And an interesting fact is he was diagnosed with ADHD at 9 years old. Now let's look at the tongue. How does the tongue posture affect the airway and craniofacial development? The image on the left is from our dental textbook. There's a zone of equilibrium. When the tongue naturally rests on the palate, our maxilla grows wide, and so our teeth can fall into place properly. And when the tongue is down, the maxilla narrows, so we have a narrow palate. Then we end up not having enough space for our teeth. And the ideal tongue position for breathing, tongue up on the palate. With a low tongue posture, the tongue is blocking up the airway. And what are the possible causes of a low tongue posture? It includes non-nutritive sucking, meaning thumb sucking, pacifier, prolonged bottle use, mouth breathing, habitual open mouth posture, tongue tie, low muscle tone. So this is a 5-day-old infant with naturally optimal tongue posture. The tongue is up. Now, in real life, let's look at how it looks like. This is my patient under MAC sedation. And we can see when we prop the mouth open, the tongue is on the palate. So this is a simulation of sleep when they're under MAC. Now, this is a child that snores at night. He has a tongue tie. When we open the mouth, we can see the tongue is down because the tongue tie is holding the tongue down. And I did a lingual frenectomy for him. We can see automatically the tongue goes back to its normal position out of the airway. So tongue ties, the image on the left, these are very obvious tongue ties. But this is not so obvious to a lot of people. But the importance of this image is when the tongue tie is on the tip of the tongue, actually the body of the tongue is able to move properly. But when the tongue tie is in the middle of the tongue, we're actually restricting the entire body of the tongue. So sometimes the cases that get referred by speech therapists or feeding specialists are cases that are attached to the middle of the tongue where there's actually more restriction to their function. So now in a pediatric dentistry textbook, there's a chapter on ankyloglossia and how do we classify tongue mobility. So in 2017, a group in Stanford Sleep Medicine, Dr. Audrey Yoon and her group, have came up with this functional classification of ankyloglossia. And it is classification so different clinicians can communicate the function of the tongue. And we have a grade 1, which is over 80%. What we do is we open the mouth, maximum opening, we lift the tongue up. When it's over 80%, it's a grade 1. 50 to 80% grade 2. Grade 3 is lower than 50%, which is down here. And then we have grade 4, under 25%. So the higher grades reflect more severe functional impairments of tongue mobility. And we know that when we assess tongue function nowadays, we don't stick the tongue out to assess function. We need to lift the tongue up because this position is very important. Now, this is a study by Dr. Kim Min-ho with Chang'an University in Taiwan. So they've shown that short lingual frenulum, it leads to abnormal orofacial growth, a risk factor for STB. So recognition and treatment of short frenulum early in life will improve normal orofacial growth. And we can also see that a reduced restricted tongue mobility is also associated with orofacial morphology. We see this V-shaped palate, a very narrow palate, because the tongue can't reach can't stay on the palate as a natural expander. Now, tongue tie restrictions causes a lot of different issues: mouth breathing, low swallowing issues, sleep issues. But we also need to look at tongue space. When we have a narrow space like that, the tongue will not fit in this area, which may cause issues for our children also. Even when there's no tongue tie, if they have a narrow palate, the tongue cannot suction up to the palate. It will still fall back into the airway, and they still can't breathe properly. Now, this sums up all the problems with tongue function, low tongue posture, ankyloglossia. So, with a tongue tie, first we may see some breastfeeding issues. They're not able to latch properly, but it doesn't stop at breastfeeding. Then we see feeding issues. These kids may not be able to eat properly. They're slow eaters, or they can't eat certain textures. They can't swallow properly, and they gag very easily. And in turn, these kids get more cavities because they can't move their tongue properly to sweep the food away, or they eat very slowly. They get recurrent cavities. After we fix these cavities 6 months later, they have more cavities. And we have a narrow palate. We see the very narrow arch. Tongue tie also causes sleep and breathing issues, and open mouth posture also causes more cavities because overnight it dries the teeth. These kids are more prone to getting cavities. Narrow arch, they may have ADHD, and they may end up with sleep apnea. And tongue ties also affects the craniofacial development. We can have a small chin, big overjet, which is a sao nga, or we have a do cup, which is a mid-face hypoplasia, and they end up having they will need orthodontics treatment. And tongue tie also causes this functional issue called tongue thrusting. So when these kids swallow, they can't move the tongue up and back. So what happens is they would move the tongue forward, and it causes what we call anterior open bite. The teeth does not close when they bite their teeth together, and this requires a lot of extensive orthodontics treatment also. And back in the day, we would associate tongue ties with speech, but we now know that our speech therapists have taught us that speech can be learned, and not all kids with a tongue tie have speech issues. Now, what do we do for patients with tongue ties? Do we release or not? Tongue function should be properly, in my opinion, should be properly assessed by a speech therapist or myofunctional or feeding specialist who is familiar with oral myofunctions prior to phenectomy procedures. Not all tongue tie needs to be released. Some can do therapy and it will be sufficient. But releasing a tongue tie does not mean the tongue will automatically function normally. We still need to improve its muscle strength. So we would need to do pre and post myofunctional therapy, which is exercises of the tongue and lip and swallowing. And for for infants and toddlers, there will need to be pre and post manual stretches. It would be ideal if they see an osteopath to relieve tensions to improve function. And also this prevents reattachment of the tongue tie. Now, this is a video of my son. I took videos of him doing myofunctional therapy. So myofunctional therapy is a set of exercise, breathing exercises, tongue exercises, swallowing, and lip exercises to improve the oral myofunction. And there is actually a lot of speech therapists in HA now that are able to do myofunctional therapy as well. So this is a study by Dr. Zaghi, a ENT in the US. They have shown that lingual phenoplasty with myofunctional therapy can improve mouth breathing, muscle tension, snoring, and clenching. And sleep disorder breathing, it's very important to note that it also causes grinding of the teeth. Back in the day, I used to tell my patients, grinding of the teeth, they're stressed out, or it will just go away. But now we know if there's a breathing issue, or tongue tie issue, or tonsil hypertrophy, it may be associated with bruxism, nocturnal bruxism. So now for a lot of our upper airway obstruction patients, they go through TNA surgery. But we know that 60 to 70% of these children after TNA surgery still experience residual OSA symptoms. And the second method is to put a CPAP on them, but this will cause facial alterations because the child is still growing. So we're making the face flat. So we don't want to do that. So nowadays we know that combining dental facial growth modification and myofunctional therapy, we may be able to attain a higher success rate for our OSA children. And so this is a paper by the Asian Pediatric Pulmonary Society. They have put together a position paper for childhood obstructive sleep apnea syndrome. And the medical treatment protocol for PEDS OSA includes medication, CPAP, surgical treatments, and orthodontic treatments, and myofunctional therapy. And the best practice guideline for American Academy of Pediatric Dentistry revised their guideline last year in 2014. And it recognizes that the critical role of airway health in children, overall well-being starting in primary dentition, which means children under 6. We shall be looking at them much earlier. And to screen for airway-related issues such as mouth breathing, STB, OSA. And they also recognize myofunctional therapy as a treatment modality for children with oral habits associated with unfavorable dental facial development. So this is a very recent paper in came out May 2025, I believe. This is it reviewed 40 papers, and it marked the craniofacial risks contributing to upper airway constriction. So the four areas that they noted was class 2 hyperdivergent, which means a big overjet, a small chin. This is sao nga. And then class 3 underdeveloped maxilla, which is a do cup. And a transverse maxillary constriction, which is a narrow palate. Or nasal obstruction and low tongue posture with or without tongue tie. So this means early diagnosis and intervention to either guide or correct craniofacial development is critical. And we see that with a high arch palate here. On top of it is also the nasal cavity. So high arch palate, you get narrow nasal cavity. So which means there's more resistance in nasal resistance to the airflow. So what we normally do is we can expand the maxilla to make it wider so there's less resistance to airflow. The other thing that we see is this was a child that was diagnosed with OSA, and we see the retrooropharyngeal area is very constricted. He had upper airway surgery, ENT surgery already, but we could see the jaw development right here. So he still can't breathe properly after the upper airway surgery. So what we need to do is we can use dental appliances to grow this mandible forward so he could breathe better. So as a dentist, what do we use for growth modification for our children? On the left, these are appliances right here. For narrow arch, we expand the upper arch for them. And for retreated mandible, we have a lot of mandibular advancement devices, or we call these functional appliances, where we could grow or help move the mandible forward. Now, let's go through a little bit of my cases. So this was an 8-year-old that underwent upper airway surgery, turbidity reduction in 2021. Still has residual symptoms of nasal obstruction and mouth breathing. He's currently on rhinitis treatment and was referred to the ENT, referred by the ENT to dental for palatal expansion. So what we see is initially started off with a 33.5 maxilla. And so I have put in a palatal expander for him. This was 1 month later. We went up to 38.5 width, and the patient actually reported improved nasal breathing. He can close his mouth more to breathe. Now, this was another child, 9-year-old, enlarged turbinates, 100% adenoids, grade 3 tonsils. He had surgery done, and we can see the class 2 retruded mandible, class 2 hyperdivergent jaw development, and we can see the very narrow oropharyngeal airway. His upper arch was only at 35 millimeter. We could see the proclined upper anterior teeth. What I did for him was we expanded his upper jaw first with the expansion. And then I've put in an appliance to help grow his mandible forward. And we could see the before, after. We could see the oropharyngeal airway have widened significantly. Now he can breathe properly. So this is another child, 6-year-old. He was a mouth breather, snoring at nighttime, and he had a tongue tie. There was only 50% tongue range of motion, narrow maxilla, a deep palate. So I referred him to a speech therapist for oral myofunction assessment, and also referred him to the ENT. So the speech therapist diagnosed him with oral dysphagia. So what we did was we did a functional release for the tongue tie, and we did pre and post oral myofunctional therapy. And ENT diagnosed him with allergic rhinitis. So he was on some rhinitis treatments, but symptoms of mouth breathing have improved, but he was still snoring. So dentally, we see that because of his mouth breathing, the palate have narrowed, and we see the teeth are not aligned properly. So I gave him an expander. This was a removable one. He can actually take this out. And there's a little screw in the middle where we turn to help expand the maxilla. So ever since we put in this expander, Mom has said the snoring has stopped. And the child actually told me that he likes turning the appliance because it makes him feel good. Now this is another boy. I want to show this case because not all children with STB issues have narrow jaw. He had a very wide jaw. this kid actually liked to eat. So he developed a very wide jaw for himself. But he was mouth breathing at night. He actually came in for cavities. He had extensive dental history. But this was the first time I saw him. He had a recurrent cavity on one of the tooth, and he needed a root canal. With all patients, I give them this intake form to fill out. And after I fix all the cavity, I noticed all the symptoms on this intake form. And mother had told me that he was diagnosed with ADHD as well recently. And the parents were actually fighting whether they should give him the ADHD medication. So I sent him to the ENT to assess the upper airway. And we did find that he had mild sleep apnea. He had surgery done, and 2 months later, he did not need the ADHD medication, and parents had reported the behavior have changed. So this is another boy, retrognathic mandible, referred by the ENT, deep bite, proclined upper anterior teeth. ENT have cleared the airway. He was just on nasal sprays. So this was his teeth. He has a deep bite overjet. So all we did was with this child, we did not put braces on him. We gave him something called a myobrace, and we did myofunctional therapy, improve his tongue function. And we could see December 2020. This is 2 years later. He had very good alignment, reduced the overjet as well. Now, this is my last case. This kid has underbite, and underbite right here, do cup, and then a tongue tie. So we know this phenotype is at risk for SDB because he will develop a hypoplastic midface. So what we did for him is we released the tongue tie. And by the way, this bite is called functional anterior crossbite. It's caused by this tongue tie because the tongue is attached to the mandible. The mandible and the tongue cannot function separately. So whenever he moves his tongue and swallows, the mandible pushes forward. So he ends up with this underbite. So we had to correct the tongue function first. So we released the tongue. We released the tongue tie and corrected the function. And we let him practice some tongue exercises. And we see this is before tongue tie. His tongue is low. And then after tongue tie, his tongue resumes normal position. Now he can do some tongue elevation exercises and separate his tongue function with the jaw function. And then I gave him this appliance here. They wear this for about 4 to 5 weeks, and we push the upper anterior teeth forward. So I have restored his bite to a normal bite before he started changing his baby teeth. And this is significant because we see before the face is flatter, we see these creases under the eyes. After his face, shortly after it came out, it grew out a bit. We don't see those creases under the eyes anymore. And now we have prevented this kid from getting SDB later on. Okay, now, in conclusion, for children with SDB, I have this house in the background because we need everyone collaborating together. We need our sleep specialists, our pediatrician, allergists, ENT, respiratory medicine doctors to treat the upper airway. And we need our pediatric dentists, orthodontists, oral surgeons, speech therapists to treat the mouth and the function inside the mouth. And without this collaboration, we won't be able to treat these children successfully. Just want to introduce our association. This is the Hong Kong Association of Dental Sleep Medicine. We established this society last year to raise awareness for sleep disorder breathing. And we had our first inaugural meeting March 1st. We had invited the Hong Kong Society of Respirology and Allergy, and also Hong Kong Society of Sleep Medicine to join our meeting. And Dr. Victor Abdullah was one of our speakers. And we wanted to empower everyone to collaborate with us to help these children. And feel free to join our membership. The fees are waived for this year. And we're actually going to roll out a series of different lectures for different disciplines. And it will be, if you join our membership, you will get emails on our meetings. Thank you.
That was a wonderful lecture. So lots of things I have not heard of. So I think we have some questions for you. What is the earliest age a child can receive treatment for reverse bite? So I'm not sure reverse bite, it means the underbite perhaps.
Yeah, for the underbite. So a lot of times it really takes, it's because of the whether the child can cooperate with the appliance to put in the appliance. So if we have to put in an appliance for the child, the earliest I've done is 4.5. Yeah. But there are cases where it's a similar case. There's a tongue tie, underbite. If we're able to spot these kids by 3 or before 3, I see these bites self-correct. So we may not need to put in an appliance.
Is there like for the in terms of the eyes, is there a critical age where after that it mandibular expanders do not help?
The expanders, for the maxilla, yes, because the sutures in the maxilla, they close or they fuse by 12 years old. So after it's fused, we're not able to use the regular expanders. We can still expand, but we need to put in little screws to pop the bone open.
Right.
Yeah.
So is it painful, the expanders? I mean, not the ones with the screws.
Expanders are definitely not painful. The child actually just feels there's something in the mouth. And when you have to turn the expander, they may feel like it's a little bit tight. But that's all. And they usually wear these for about 6 months. Yeah.
And contrary to what parents will believe, it does not make the teeth, when we saw the would it make the increased gaps between the teeth?
Yeah, so the purpose of these expanders is to increase gaps between the teeth so then the other teeth can come in properly.
Right.
Because a lot of these cases, we could see that the teeth have crowding. Right?
Yep.
So when we expand the maxilla, then we allow the teeth to kind of fall apart into the right space in the arch.
Mm-hmm. And so when we decide whether a child needs braces, then when do we decide whether we should actually bring the teeth in with orthodontic treatment or whether we should expand the teeth? I mean, do we rely truly on what you presented? So maybe the behavior, maybe the breathing, and check the child's tongue? Is that how we decide?
Yeah. So with expansion, nowadays. Because there's a lot of dentists and orthodontists that we're all looking into the airway and sleep disorder breathing, and there are studies out there, or there are papers out there that indicates, let's say if we have to take teeth out to do braces, we're making the mouth smaller, and there's no space for the tongue, and these patients later on in life may have issues with airway breathing. So then now the new thought is, why don't we do early intervention? We help them grow earlier, so then the maxilla width grows to where it should be to accommodate all of their teeth. Because our jaw development, we should be able to accommodate our teeth ourselves, right? Then what happened? Is it because of a tongue function issue, or is it because of mouth breathing, it got smaller? So essentially, we're just making it wider so it's to the size that it should be. Yeah. These children that we do early intervention on is usually anywhere between 7 to 10 years old, and I think the best way is because for children to see the dentist, right? They start very early on. The guideline is really by 1 year old they should come in. So then I think the best thing to do is if we can see them a lot earlier, we can actually guide their development a lot earlier versus trying to fix issues later on. Yeah.
Because a lot of parents would ask us, 我小朋友好多鼻鼾，即係究竟以前我哋就會話因為佢未 fully develop 可能啲軟組織比較 floppy 唔夠 tone 正常嘅。咁其實即係憑你所講I don't think it's actually really all that normal.
So nowadays we know from research and studies, 鼻鼾, over like three times or more every week of 鼻鼾. It doesn't have to be the entire night they're snoring. But it's not normal, and it's normal when I've learned this from my ENT colleagues. It's normal when they're very tired or when they have upper respiratory infection, but normally they shouldn't really be snoring. Yeah, and specifically if 3 times or over every week, then we shall send them to the ENT maybe to check what's going on, where's the obstruction at. Yeah.
Right. No.
Irene 我想問一個問題咧，就係頭先你講 tongue tie，我覺得好你知我哋近時嘅 training 就話tongue tie 好少嘅，其實好少 tongue tie。
係啊。
咁咧而家聽你講咧，似乎 tongue tie play a very very important role。咁我想問啦，我哋應該由幾時開始 systematically 咁樣 examine 個 tongue 咧？嗱，你知 pediatrician 就有 newborn screening 啦，咁咧就其實就已經有啲 lactation consultant 就話：喂，唔得喎，呢個有 tongue tie 喎。咁咧就可能會好啲嘅，即係做咗個小手術之後就會好啲嘅。咁我哋有時候唔係好信啊，即係咁而家聽你講咧，就似乎即係應該有一個好 systematic 嘅 approach 去 examine 個 tongue， 同埋要即係 document 咗佢。你可唔可以話俾我哋聽，即係其實係咪每一個階段我哋都要睇清咗條脷咧咁樣？
係 definitely。So from infancy。係啊，咁因為I believe 咧，點解我以前啲 study 係我覺得好少幾個 percent 有 tongue tie。I believe the tongue tie that we're looking at for those studies are the anterior tongue ties， 黐喺前面嗰啲。
Right.
But we're not looking at the ones that are maybe stuck in the middle of the tongue. Because how I see it is we all have a tissue under the tongue that's called the lingual frenulum。我哋個個人都有 whether 佢黐得前啲係後啲 affects the function。And we should start infancy, whether to see whether they have breastfeeding issues. 跟住 the next thing, let's say no issues, but you know 可能個 tongue tie 都係黐得前啲 then we can observe until 佢開始食 solid. Then we may find these kids have feeding issues. 係啦，咁一路要睇住 and then when they come see us for teeth, we may see jaw development issues. So it definitely should start infancy. 係因為呢個 tongue tie 好多時候like let's say when it's released as a baby, that's why I emphasize the stretching and the exercises are actually very important when we release babies. 因為我哋 after release babies, it's not only for the breastfeeding. We need to make sure this tongue is functional for later on in life, for breathing, for jaw development. 咁所以 you know there should be a protocol on how this should be done properly. Yeah.
其實呢個我就係想問你嗱，頭先我睇咗你個 talk 咧，其實頭先你講嗰啲咧夠唔夠我哋可以攞嚟做一個 protocol？定係話我應該再同你拍多條片，然後咧就即係唔係呢個我唔係講笑，呢個好重要。其實如果聽你講就係即係我哋喺好早嗰時應該就睇個 BB，即係呢個 part of 我哋 examination。咁頭先你講就話即係 introduce solid 嗰陣時，又或者再遲啲佢可能有其他嘅 sleep 問題嗰時，即係你可唔可以話到俾你聽？我哋頭先你講嗰啲夠唔夠 form 一個 protocol？定係咧我應該即係再整一個？唔係，我覺得好重要喎！即係如果我哋想 promulgate 成件事咧，其實要 systematically 咁樣做。係嚇。
我覺得there's more 頭先我講嘅好少係啊there is a lot more to it 係點樣個 protocol 應該點樣啊？做點樣 spot 呢啲 tongue tie 啊？What exercises are you doing？ you know 係啊？要做幾耐啊？因為it's a whole different lecture 係啊。
太好啦，因為咧其實咧我話咧咁多年咧就已經有好多人問我阿彪你可唔可以揾個 expert 講下呢個 tongue tie 咁？我話死啦，即係我都啞咗，因為我未識你嘛嗰時。咁可能我哋真係嗱，你真係要應承我哋下一個 talk 咧，就麻煩你講一講個 tongue tie。我希望由即係個 newborn 嗰時我哋點 examine 啊，個 approach 係點樣 document 啊，點樣大家 unify 咗佢啊咁樣。
係啊，因為應該係即係 documentation， 因為個個describe tongue tie 都覺得係即係用唔同嘅方法 describe tongue tie 或者睇嘅方法都唔同。But 依家其實出邊好多 classification that we can use as a protocol to communicate with each other 係啦，係啊。咁因為有時話有個 mild tongue tie，what does that mean？What's a mild tongue tie？ 係咯，so I feel like there needs to be a protocol where we can communicate effectively 係啊。
Because 即係頭先你講話，我哋而家有好多 唔同嘅 specialty 咧 collaborate， 即係我都好恭喜你哋 form 咗呢個會。其實呢個好重要，我覺得。咁又其實我哋真係自己都 witness 到，其實 sleep apnea 喺細路仔其實好深遠嘅 effect 嚇。咁我覺得我哋真係要第一件事統一晒啲嘢先，即係啲 documentation 啊、terminology 啊咁樣。咁我覺得非常之有用嚇。咁我見網上仲有一條問題，就我不如放大嘅，或者我讀出嚟好唔好啊？阿 Timothy 好嘛？
好啊。
What are your thoughts on the lip tie in newborn? Really need cutting? In the past, these were torn frenulum from force. Seem not enough just to snip tongue ties. Now lactation consultant thinking about hip ties too. 我估係咪？你明唔明？
我明嘅，
我唔係好明佢個問題。
In the past, these were torn frenulum.
我試下放大咗俾大家睇下。
即係其實即係除咗條脷有個 frenulum 口唇都有。
係啊，有個叫 lip tie 嘅 ，which I did not talk about today. But lip tie is important also on newborns for feeding purposes. Well, first, for lactation consultants, when they need to latch properly, the latch not only requires the tongue, the lip need to be able to wrap the nipple. From my understanding, I am not a lactation consultant, but this is what I've learned from them. So if the lip and the tongue cannot latch properly, they are not able to feed properly. And these babies, a lot of times you will see blisters on the lip. 因為佢個 latch 唔到啊，咁佢咁樣整住去啜奶，然後就見到呢好多個嘴唇有 blister。So then these lactation consultants would recommend snipping the lip tie，等佢嗰個嘴唇可以反起 ，and then they can latch properly. And the lip tie is not only important for breastfeeding. Then later on, what I look at is 我哋發覺咧，如果個 lip tie 好粗嘅小朋友咧 ，what happens is they get a lip that curls up like this，即係好似腰咗上去咁樣。And a lot of times, these kids naturally 就係個嘴係開住嘅。And we know this open lip posture會 cause 哨牙。And the key is between 3到5歲嚇，the maxilla grows. It's the greatest growth in our entire life. And I see these kids, if they're like that, they have more of either 哨牙啦or more gummy smile. Yeah, later on in life, you see vertical maxillary excess. That's what we call a gummy smile. So I would encourage snipping it if that's an issue too. 係啦。
咁呢個多啦。咁佢繼續話 ，However, if we refer to the dentist, not everyone happy to cut. The ones who do by laser charge more than $10,000. Therefore, parents go on to the internet and expect the pediatrician just to be able to cut it.
That I don't know what to do. I know there are pediatric surgeons. Any pediatric surgeon which there are pediatricians that does it. The key is. I feel like it needs to be done properly. That's why, I feel like there needs to be a protocol on how should it be done.
咁我應承啊，多啦嗱，好快咧就會請阿 Irene 上嚟講個tongue tie。我覺得呢個咧係我欠嘅債嚟，我一定要還嘅呢個。咁咧因為其實真係好多人問過我，咁係啦，咁佢繼續講嘅 ，This is a real problem in private because as soon as someone says tongue tie, lip tie, and it's a self-fulfilling prophecy because then the mums cannot breastfeed and everything is blamed on this。啱嘅，其實即係我好似講得好輕鬆，其實呢個係一個真係一個 issue 嚟嘅，即係我哋都有一個dilemma，有啲人問我哋，即係究竟做啊唔做啊，點樣做啊咁樣。咁我估第一件事真係要 document 咗先嚇，邊啲係真嘅，邊啲係假嘅。咁我亦都見即係有啲好輕易就做啦咁樣。咁我諗即係我哋每做一個 procedure 或者每做一個手術，其實都係要 justification 嚇。咁好啦，咁我諗非常之有用啦嗱，即係喺 好快咧，我會再請你。不過一定要7月之後啊，7月之後我會請你。
我諗應該叫埋個 either lactation consultant 或者一個
Pediatrician
speech therapist 或者 pediatric surgeon 或者 malfunction， 即係幾個即係成日睇呢啲 tongue function 嘅人一齊。
咁你個會咪啱啱好咯？
係
你個會咁多 collaboration。
係啊。
我希望呢個係你哋第一份功課啊！唔係真係嘅，即係我覺得真係呢幾年太多人問啦。
係啊。
咁咧我交唔到功課，今日非常之好，我非常之開心嚇。咁我應承阿多歐，咁咧就我哋會揾另一個video 咧，或者一個 session 咧，真係講呢樣嘢。咁就哇呢個都似乎係今日最多人問嘅問題。咁其實我想再問咧，就係而家呢個會咧，而家你 form 嘅呢個會咧，對個 training， 即係嗱牙科，即係我哋都好陌生嘅，即係牙科醫生。其實你哋即係點樣分嘅？即係有啲牙科就即係淨係睇牙嘅，咁有啲就睇其他嘢嘅，即係點樣分嘅？我哋唔熟悉嘅。
我哋牙科都係好似你哋咁有唔同 specialty。
係。
嚇咁我哋有 general dentist 啦，咁有好似我 pediatric dentist 啦、箍牙醫生啦，或者係啲 prosthodontist，we have different specialties as well。係啊。
我哋喺個qualification 嗰度啊，睇唔睇到嘅？
通常睇到嘅，如果喺香港 train 嘅，通常睇到。
係。
係啊。
係。咁而家最缺係咩人啊？
最缺
係咩嘢？即係
最缺係其實最少，我覺得係。可能係 pediatric dentist 啊，係啊，因為其實咁樣嘅，我哋有好多 pediatric dentist 喺政府嘅睇牙科保健，咁我哋喺 private 係比較少嘅其實。
另外就係如果你睇開即係牙科保健咧，頭先你講譬如嗰啲問題咧，佢哋係會察覺到定係佢哋都要 training？
咁我哋枕住我哋個 Hong Kong Society of Pediatric Dentistry 都有一啲 meeting 嘅，會講呢啲 issue 咯。咁 so everyone should be aware of it。
就算啲 dental hygienist 佢哋都知嘅，定係唔知嘅？因為我知道佢哋如果去牙科保健嗰啲就唔係牙醫幫我哋睇先，即係啲 dental hygienist 幫我哋睇。咁佢哋嘅 training 有冇 cover 呢啲？
好似即係 let's say if we go out to CME 咁就會識係啦。咁如果冇 CME 就我唔知個 requirement for hygienist 係咪需唔需要？
呢個好重要嚇，即係頭先你講嗰啲問題嘅，如果早發現係即係 amenable to treatment 啊咁樣。咁我哋一齊努力啦，要即係將件事即係令到大家都。
所以今日好高興你哋請我嚟，因為即係我哋同 pediatrician 嘅 collaboration 好緊要，係啊 ，because you guys are the first to see them， 係咯。咁所以 this only works if we can work together。
咁咧就好開心我今日就第一就學到好多嘢啦，第二就你應承我解決我呢個
tongue tie
啲人問我tongue tie嘅問題。咁咧就我好多謝 Timothy。咁咧就其實佢今日好忙嘅，佢都即係應承過嚟做呢個 moderator。咁好感激你。咁咧就幾樣嘢嗱，台面咧我麻煩你送一個紀念品俾 Irene 嚇，其中一個你喎嚇，你攞面頭嗰個係啦。
多謝晒。
以為先，咁咧最啱一個 pediatric dental surgeon。咁另外呢個我就送俾你。
多謝。
咁我一陣間要俾多個你，就幫我送俾 Ethan。咁咧就我好希望佢可以再俾啲作品我哋喺呢個節目嗰度播咁啊。